Acute renal failure is the sudden decrease in kidney function. The CDI industry has two clinical criteria that are commonly used as references for the clinical criteria for acute renal failure: the RIFLE criteria from the Acute Dialysis Quality Initiative Work Group, or the KDIGO criteria from the National Kidney Foundation. Please check with the hospital's internal policies for approved criteria. The serum creatinine level and measurement of urine output is the first step in determining if a query opportunity for acute renal failure is warranted. An increase in BUN can be due to many other conditions that is not used very often as a supporting clinical indicator for acute renal failure. An increase of creatinine of 0.3 is an acceptable clinical indicator. The trick to applying this measurement is knowing the patient's baseline creatinine. If the patient's baseline creatinine is not identified by the physician, then the lowest creatinine measurement during the current hospitalization can be used. If the patient comes in with increased creatinine and it declines during stay, then the lowest serum creatinine measured during the stay can be used. It is also best practice that more than one increased creatinine level is referenced. A one-time increase does not support a diagnosis of acute renal failure. A reduction in urine output is also a significant clinical indicator. Documentation of urine output measurements is most often found in the nursing notes. Documentation of less than 0.5 milliliters per hour for more than 6 hours is a solid base criteria. An abnormal urinalysis can lead a coder to consider looking at other clinical indicators for acute renal failure. Urinalysis reports stating the urine is muddy or bloody are abnormal findings that could be related to a kidney disorder. Documented granular epithelial cell cast, proteinuria, hematuria, and uremia represent a possible kidney disorder. There are quite a few key words used that can alert the CDI coder to a possible query opportunity. Anuria, oliguria, hematuria, hypovolemia, dehydration, proteinuria, and uremia are often associated with acute renal failure. Anuria is a decline in urine production, and oliguria is low output of urine. Hematuria is blood in the urine, and proteinuria is excessive serum protein in the urine. Urinalysis reports may document hematuria and proteinuria. Uremia is urea in the blood. Acute renal failure due to ischemic tubular necrosis is the most common cause of acute renal failure. Tubular necrosis is severe damage or death of the kidney's tubular cells. This can be caused by ischemic or toxic event. Sepsis, hypotension, drug toxicity, obstruction are common causes of ischemic tubular necrosis. Acute renal failure due to renal cortical necrosis is rare. The condition is caused by significantly diminished renal arterial perfusion secondary to vascular spasm, microvascular injury, or intravascular coagulation. Acute renal failure due to uric acid nephropathy is most often due to overproduction and overexpression of uric acid, also known as hyperuricemia. Acute renal failure due to interstitial nephritis is caused by an inflammation of the kidneys. Interstitial nephritis is an inflammation between the renal tubules. Interstitial nephritis can be caused by an autoimmune disorder of the kidneys, infections, or toxins. Acute renal failure due to glomerulonephritis is caused by inflammation of the glomeruli. Acute renal failure due to obstructive uropathy is due to urine not draining through the ureter. Common causes of obstruction include uropathy, bladder stones, kidney stones, BPH, bladder, ureteral, colon, cervical, or uterine cancer. Common clinical indicators for acute renal failure include anuria, anemia, blood loss, internal or external, bladder stones, burns, dehydration, drug toxicity, diarrhea resulting in volume loss, hematuria, hyperuricemia, hypovolemia, hypotension, kidney stones, oliguria, proteinuria, nephritis, neoplasms, sepsis, uremia, vomiting resulting in volume loss. Common diagnostic tests for acute renal failure include BUN, creatinine, GFR, urine output measurement, urinalysis, and common therapeutic treatment of acute renal failure includes dialysis, IV fluids, nephrology consults. Possible query options for acute renal failure: acute renal failure with ischemic tubular necrosis, acute renal failure with lesions of renal cortical necrosis, acute renal failure with uric acid nephropathy, acute renal failure with interstitial nephritis, acute renal failure with glomerulonephritis, acute renal failure with obstructive uropathy, acute renal failure due to sepsis, and acute renal failure.